I'll hand over now to Professor Simon Rule. So Simon is a clinical haematologist from Plymouth in the United Kingdom, who was out here as a guest speaker at our National Haematology Society meeting. Simon's main interest is in mantle cell lymphoma, which is one of the important subtypes of non-Hodgkin's lymphoma. He has a publication lists the length of your arm, so a very important person in the lymphoma space. And as of this year is now the Deputy President of the British Society of Haematology. So we're very grateful that in the context of what is an incredibly busy itinerary that he has, that somewhat at the last moment he's volunteered to help us out today. So thank you very much, Simon.
Pleasure. I know it's an absolute pleasure to be here. I do a lot for the Lymphoma Association in the UK, and I think it's the most valuable organisation we have. It's all very well patients talking to me about side effects and what have you, but talking to people that have gone through it's far more useful. Just to reassure you as well, let me show you that I am one of you, right? Well, almost one of you, okay? I've got a bit of both. So I am part Australian trained. I'm not sure that's going to reassure anybody. I've decided not to show any slides either, because what I find is that when we doctors show presentations, we show slides of things like survival curves, which actually aren't terribly, they're a bit emotive for patients to see that kind of thing, and I don't think that's terribly helpful. So rather just talk about the generality of lymphoma, where the treatments are, and where the future's going to be. So I have a very peculiar practice. I just do lymphoma for a living. So I work in a big hospital with a big catchment area, and I have a lymphoma clinic for all lymphomas. And then I have this subspecialist interest in mantle cell lymphoma, which is a very rare type. And Jason's right, the incidence of lymphoma is going up, and what's even more confusing, of course, is there's over 70 different types, which makes it even more confusing for everybody. So yes, I have mantle cell lymphoma interest, and within that we do lots of new drugs. So all the kind of new drugs that you read about and hear about, I've probably used most of them. And one of the kind of recurring themes when I'm talking to not so much patients, I think, to my colleagues, is there's a real appetite for some of these new drugs, and everybody's very excited about these new drugs. And I just remind people that chemotherapy works, and it works in lots of different types of lymphoma, and of course cures the commonest type of lymphoma. So we have to keep that in mind. Some of these new drugs might, in the future, change the paradigm for some of these diseases. But I've certainly had I had one, I was telling Jason, a conversation with a patient literally this last week who was very reluctant to have chemotherapy for her diffuse large B-cell, which has a 70% chance of curing her, because she was worried about what was going to happen 10 years down the track, and the reality is there is no 10 years down the track unless she gets treated. So sometimes, we have to remind people that the treatments we've got, whilst they appear unpleasant, and for some patients toxicities are an issue, it's short-lived, and hopefully you get over it and you're back to normal. So with these new drugs, there is certainly, in some diseases, certainly the disease I manage, particularly mantle cell lymphoma, we've got these new oral therapies which look really very, very good, and that may well change some of the treatment paradigms, but for many lymphomas that won't be the case. So I've used almost all these new drugs now, and there is a transformation away from what people would consider conventional or traditional chemotherapy towards non-chemotherapy type approaches. And I think one of the things that's a bit difficult to get your head around is what's chemotherapy, what's not chemotherapy. Some of these non-chemotherapy drugs kill cells and cause problems. That's chemotherapy in my book. So it's sort of old-fashioned chemotherapy is what people are comparing with. And some of the new drugs have their own side effects. So just because it's not a chemotherapy doesn't mean it's not without its problems. Having said all that, things are certainly improving. There's no question. And if you look at the outcome in the disease I manage, you can see that the long-term outcomes of patients are getting better and better and better. And one of the dangers, I think, with the internet particularly, is you read things and patients come in terrified, saying, well, this is really bad, this is really bad. And actually the reality is much better than that. So that's one of the good things and the bad things about the internet is it gives you information, but sometimes it's not necessarily the right information. But if we talk specifically about the disease I treat, mantle cell lymphoma, because that's the one I know the most about. So here's an aggressive type. I'm not going to ask for a show of hands. Here's an aggressive lymphoma that is, on the face of it, an incurable disease. Sounds awful. But within that, we recognise, and this is one of my research interests, about a third of patients don't need treating. You can just watch them. Now, that seems counterintuitive. You've got a nasty type of lymphoma, you can watch it, and in some people it just jogs along in the background without anything. And it's not that they've been taking any particular herbal remedy or anything, that's just the way it is. So how do you work that out? So we've got in the UK, we've got a large study where we're just following people, and the idea is we're going to try and find some kind of marker at diagnosis that'll tell you whether somebody's disease is more aggressive or less aggressive. So I think understanding the biology of lymphomas is very important, and that will ultimately change our approach to management, and that might be being less intensive with treatment, and in some situations being more intensive with treatment. So information's important. One of the challenges with lymphoma is getting the diagnosis right, and many of you won't, I guess, be aware of that, but getting the diagnosis right at the beginning is very important, and certainly in the UK, I can tell you there's been a big push to centralisation of pathology services, because if it's a general rule of medicine, if you see lots of something, you're going to be better at it than if you see not very much of something. So getting the diagnosis right in the first place is very important. And within that diagnosis, again, we're starting to understand certain prognostic factors, which right now may not make a difference to how we treat, but in the future probably will. So understanding patients whose disease is more aggressive and less aggressive, and then tailoring your treatment accordingly is important. As I said, in the disease I treat, we've got these new tablets. That's what I've just been talking about, actually. Drugs called Btk inhibitors. They're oral therapies. They've got really very few in the way of side effects. Look highly active in patients after chemotherapy. And so, again, in the UK right now, we've got a trial comparing that treatment against chemotherapy as first-line treatment for lymphoma. So you're either getting chemotherapy or getting non-chemotherapy in the context of tablets. Unfortunately, Australia couldn't join that trial because your regulators don't allow rituximab maintenance. If you did, you'd be in the trial as well. Actually, Australia and the UK share a lot of similarities around getting access to drugs. I think actually you're slightly slower than us, which reassures me because we're much slower than the rest of Europe. And of course, we're about to become out of Europe as well. It could make things even worse. But anyway, so these new drugs have the potential to change the whole treatment paradigm. And this study that we're running, we've got 150 patients in it now, half getting chemotherapy, half getting the tablets. The idea is to see whether it's as good, at least as good. And if it is, we know it's got far fewer side effects. So it's about not just does it make you live longer, but in the process, are you feeling much better? Have you got fewer side effects? So part of the equation is making people live as long as possible. That's true. The other, maybe more important thing is having quality of life during that period of time. You're too young to remember interferon, but the drug we used to use a long time ago, interferon, used to make people live a bit longer with certain hematological cancers, myeloma and follicular lymphoma, actually. But you felt awful. So, it bought you time, but the whole time you felt terrible. So nobody uses that anymore. So that balance between living longer and feeling better in the process is important. And a lot of that is having an informed conversation with patients. I think one of the things I always find a bit frustrating, because I see a lot of patients for second opinions, is that their original doctor's never actually been terribly honest with the patient about what they're likely to achieve with the therapy, what the outcomes are going to be, and then they read things on the internet, they challenge the doctor doesn't like the challenge, it all kind of falls apart, and it should never be like that. I think I always take the view that I'm going to tell you what I want my mum to know, or what I want my brother to know, and if you treat people like that, then that's the right way to go. So, so there's some very exciting things. You may be aware of this CAR T-cell therapy that's coming for aggressive lymphomas. There's few patients in Australia, very few people in the UK. It's predominantly happened in America. So this offers a whole new treatment paradigm, if you like. I'm a bone marrow transplanter by training, and CAR T-cell, in a sense, is a bone marrow transplant without all the paraphernalia that goes along with it. And in certainly aggressive lymphomas, it looks very, very interesting. So this is basically enhancing your own immune system to go back and target your tumour, because your immune system's lost the ability to do that. That's why the tumour's there in the first place. Not without toxicity, of course. So all of these things, you don't get something for nothing. You start playing with your immune system, you can get toxicities. But as we get better at doing this, we understand how to manage that. Then there's a definite prospect that we can cure more patients, certainly with the aggressive lymphomas. There's a challenge there for governments and regulators as to how you do that kind of thing. So in the UK right now, NICE has said yes to this form of therapy, but that has to be done in a very carefully regulated way. Only 8 centres are going to be allowed to do it to start with, and they have to be inspected first, and then it'll get rolled out into a bigger number of centres. So when you put expensive and difficult therapies out there, you've got to put it in the hands of a small number of people so they get the experience. So one word of advice I'd give you, who's read Lance Armstrong's book, It's Not About the Bike? Anybody read that book? You read it? So he got testicular cancer, and he got it in his brain and his lungs, and he was cured, basically. So I got this book. Somebody said, you should read that, it's really interesting. And he's a bit mad, and he's clearly an obsessional individual. And the reason he got where he got with the treatment was he found the best person. And that's a very important message, I think, certainly with rare types of lymphoma. Go and find somebody that does it regularly. And if you ask your doctor for a second opinion and they're very reluctant, you probably don't want them looking after you. A doctor that's happy to give you a second opinion is very confident in what they're doing. That's a good rule of thumb. Okay? And it might be that you're getting exactly the right thing, but sometimes, there might be things that that you're not aware of that are out there. It's not a controversial thing to say, is it? No. I think that applies with any rare disease, actually. Go and see somebody who does it for a living, and they're going to have more expertise than people that don't. So that's important. There are lots of things coming. Again, that I would just counsel people, you read some amazing stories on the internet and just be very cautious when you actually, the reality sometimes isn't as good as the internet would tell you. Sometimes it is. And some of these, certainly the Btk inhibitors are absolutely transforming the lifestyle of some of my patients. So rather than ramble on, I think it's always more useful if I answer questions, because I'm just sort of, I'm a generalist, but mantle cell lymphoma I can talk about. Because you'll have things you want me to talk about. One thing I would say is I'm not going to comment on anybody's individual treatment, because I won't know the whole story. So if you say a friend of mine's got this, I know that's not the case. So I've done enough of these things to know that. But I can talk in general about approaches or treatments or anything you want to talk about, actually. So how do you want to play it? Oh, there we go. Go on.
I'm more interested in follicular lymphoma.
Yeah.
Is there any advice that you can give in terms of people helping themselves with longevity and, like Haematology is quite good in terms of biopsy. Advice in terms of staying well?
Yeah, I think that's a difficult one. And follicular lymphoma is really a chronic illness now. And for some patients, if you have your upfront chemotherapy and you haven't relapsed at 2 years, you've got a complete remission at 2 years, your life expectancy is pretty much the same as a normal population. So that's changed quite a lot. The advice I always give people about lifestyle and what have you, there's no one or two things that actually makes a big difference as far as your disease is concerned. But being fit's a good thing. So being fit, physically fit's a good thing. Not smoking is a good thing, and the reason I say that is if you come and see me and you are fit, then all my options are on the table. If you come and see me and you're 130 kilograms, you smoke and you've got diabetes and what have you because of your obesity, that really impairs what I can do for you. So being fit makes the treatment options that much more easy. So being fit, be a little bit careful about, I imagine being here is very similar to back home. There's all sorts of claims for, this diet, that and the other, that cure cancer or make things better. Anything that's an extreme is probably not something to pursue, I'm all for it. Is that the right answer? Yeah. There's no... If your doctor says don't drink alcohol, get a second opinion, that's for sure. It's the same story, it's everything in moderation. If you drink lots and lots of alcohol, then your liver's a bit, struggling a bit, and if I give you a drug, and lots of these drugs are metabolized by your liver, then that causes problems. That goes for some of the alternative therapies as well, by the way. Some of these things, they might appear safe, or because you're not being prescribed them, doesn't necessarily mean that your body's not having to metabolize these things. So everything in moderation, my dad always used to say, although he didn't practice that. He died of lung cancer, he wouldn't stop smoking, so it's not the best role model. But yeah, I mean, anything that's an extreme, I think, is not right. So drinking, if you want to drink, yeah. But not drinking, you might feel better for it. I usually do. Well, it depends what kind of immunotherapy you're talking about. We know in follicular lymphoma that adding rituximab, so that's immunotherapy, improves the outcome from the chemotherapy alone. We know that. So there's no question that adding the immune component to the chemotherapy, whatever the chemotherapy is going to improve outcomes. It's a slightly different story about whether you continue with immunotherapy after the chemotherapy, and there's big sort of debates about whether that is a good thing to do. Most of us do it. So in the UK, well, this is talking about something called maintenance. So you give the chemotherapy, then you give rituximab. We give it subcutaneously for up to 2 years. And that improves what's called progression-free survival. What does that mean? That means that you will live longer without disease coming back than if you do have it. But it doesn't make you live any longer. So ultimately, your survival, if you like, is the same for various reasons. So one of the things about immunotherapy is tailoring it. Who gets the most benefit from it? And so there's a study that's just started in the UK. It's actually running in Australia as well, where we're taking people with follicular lymphoma who need treatment, giving them chemotherapy with rituximab, but then doing a PET scan at the end. And if they are PET negative, in other words, there's no obvious disease, then they're getting randomized. So by chance, they're getting immunotherapy or nothing. Because those patients might be the ones that don't need it. And with all treatments, you don't get something for nothing. So if you give immunotherapy, rituximab, for a couple of years, there's an incidence of chronic infections. It just lowers your immune system. They're not severe infections, they don't kill you. But I'm regularly stopping rituximab for patients who've got chronic sinus problems or chronic chest problems, and it's not benefiting them if that's impairing your quality of life. So I think it's, again, with lymphoma, it's very much individualized how you manage it. There are certain situations where this is the treatment. There's no question this is the treatment. But, immunotherapy post-chemo is an individual decision. So my practice in a more elderly population who don't have very much disease in the first place, I won't do it, because all I'm going to do is introduce toxicity. Their survival is so long with the disease, they're going to die of something else, to put it bluntly. So what I don't want to do is introduce toxicity with the therapies I'm going to give them. In a younger patient, I might be more inclined to use a rituximab maintenance setting, particularly if they've got bulky disease, if they've got a lot of disease to start with, because they're the ones that are probably going to get the most benefit from it. Yeah, so obinutuzumab, or GA101, is a sort of super rituximab. Again, doesn't make you live any longer than rituximab. Has some issues. I mean, it's quite difficult to give, lots of infusion reactions, and more infections, again. That's available in the UK, but very few people are using it, actually. They're more likely to be using rituximab, because rituximab is a much easier drug to give. Can you give rituximab here? Yeah, I mean, so subcutaneous rituximab is such a nice thing for patients. So again, it's slightly better probably from a progression-free survival perspective, but it's very minor actually. So it's not a slam dunk. It's not, if you like, the next big thing. There are some situations where it might be better. In a relapse situation, when patients have had a shorter remission from their rituximab-based treatment, that may well be beneficial there. But that's not many patients. Yeah. There you go, immunotherapy. Yes, sir.
I have early stage mantle cell.
Oh, okay. Right.
So, I mean...
You're being watched, are you?
Watching and waiting.
Yeah.
But also, my doctor said, you probably might be comfortable with this, get a second opinion. And he was...
He's a good doctor then.
Yeah. And I happened to get it off a chap who's up here in Mana, and he suggested, well, why not try some radiation? You've got nothing to lose and everything to gain. So that was probably 12 months ago. I don't have a clear picture, and maybe no one has. I'm just curious what might be down the track. Who knows?
So mantle cell lymphoma, for those that don't know, is an aggressive type of non-Hodgkin's lymphoma, and if you see, it's an aggressive form of mantle cell lymphoma. It's a disease that men get, not women, predominantly. 3-to-1 men to women. It's an aggressive disease, but there is a group of patients, as I said earlier, who've got a very indolent behaving disease. It just sort of jogs along in the background. And I've got some patients untreated for 10 years. The trouble with this lymphoma is there's nothing you can measure that will predict what's going to happen to you. And so leaving people alone is often the right thing to do, because you might be surprised. You know, if you're treated straight away, then you get a response. If you leave alone, you have no idea, and it doesn't affect how long you live. That's the important thing. And a big change with that disease is a move away from chemotherapy to these non-chemotherapy approaches. So, as I said, we're running this study of ibrutinib, a tablet, with rituximab, subcutaneous, as treatment for an aggressive lymphoma versus chemotherapy. So it's a randomized trial. I mean, it'll be a few years before we know the answer to that, but that style of treatment away from a chemotherapy approach, I think we're going to see that, you know, further on down the track. One of the other things I always tell patients is that, you know, waiting until you need treatment, not for all lymphomas, some lymphomas you've got to jump on them straight away, the more aggressive ones, is a good thing, because basically, you know, in a broad way, the longer you live, the longer you are waiting for new innovations to appear. So I've got patients in my clinic who came to see me 6 years ago when everything had failed, who've been on a series of clinical trials and have gone from one drug to the next and are fine. So these things are all, you know, the pharmaceutical industry get a real kick in, but actually that's where drugs come from. And they're inventing new drugs all the time, and good drugs with few side effects are going to sell. So actually, you know, these things are coming, and it is an exciting place. 10 years ago, there was nothing for the condition you're talking about, and now there's lots of potential things. So that was the right thing to do. If you've got local disease, a bit of radiotherapy is a good idea as well. You've got a good doctor, yeah. Two of them, yeah, exactly. Yeah. Yeah. H. pylori, yeah. Invented in Australia, that was, you know.
They reckon that can cause you can get lymphoma.
You can. Yeah, you can.
But my oncologist said he doesn't think so.
Doesn't he? Okay. Well, he's not right. So.
No, he said, no, really. See, I'm into it.
Yeah. So H. pylori is a bug most of us are exposed to, and in some patients it can induce a rare type of lymphoma in the stomach. And what's interesting is if you treat the H. pylori with antibiotics, the lymphoma goes away. So one of the things with lymphoma is that anything that sort of chronically stimulates your immune system can lead to some types of lymphoma. And if you remove the stimulus, the lymphoma can go away. So the lymphoma, unlike most of the solid cancers, lung cancer, bowel cancer, breast cancer, is sort of very involved with your immune system. So, for example, if you've had a kidney transplant and you are constantly being immunosuppressed, you have to take immunosuppressive drugs to stop your body from rejecting the kidney, your incidence of lymphoma goes right up because you're basically calming your immune system down. If you get lymphoma and you stop the immunosuppression, the lymphoma goes away. So this play between your immune system and your lymphoma is important. In some disease, not all of them, but in some of them it is. And that's why lymphoma is common as you get older, because your immune system's not quite as smart as it is when you're younger. But yeah, H. pylori causes certain types of lymphoma. Also causes stomach cancer. You should know that. Anyway.
They say that you can get bowel cancer.
Yeah.
But I didn't. I was at pneumonia, and then I found out I had lymphoma, and I just had my second bone marrow yesterday. They found a little thing on my head.
Yeah, well, a little bit. I wouldn't worry. Within lymphoma, I wouldn't worry about a little bit.
No, I'm okay though. Not
Yeah, I can see that. What else? Yeah.
We have some online questions.
Oh, okay. Yeah,
Can
good.
we steal your microphone?
Of course you can.
Because you could use it.
All right. Yeah, yeah. I'm loud enough anyway, aren't I? Yeah.
Not that my voice is very quiet, but just in case.
Thank you, Simon. So leading on, I've put them into themes here, and there's something quite similar to that lady's question. So you've answered about those particular viruses, but are there any other viruses with follicular or mantle cell, like we see the correlation between EBV, say, with Hodgkin's lymphoma and Burkitt's? Is there anything else that we know about or are looking into that may cause?
I mean, the short answer is no.
Yeah.
You know, you just described the sort of the most frequent ones. hepatitis C can then cause some rare lymphomas, but by and large, no. We don't recognise. For most lymphomas, we have no idea what triggers it. We know it's common as we get older. We know there are some particular situations I've just described. If you're immunosuppressed, that is more likely to happen. But no, outside of the things you described, there's no clear causative agent. And I guess, lymphomas, like many cancers, there's probably two elements here. There's something that triggers something that goes wrong in your body, and there's something in your body that doesn't actually recognise it, and so things take off. So, you can live in the same house, eat the same food, be under the same overhead power lines, not that causes problems, and somebody gets a disease and the other one doesn't. So why is that? There's some environmental insult, probably, that triggers it. And that might just be aging, it might just be, age. And then there's something about you that when this happens, it triggers a disease. But we don't know. We don't. And the bottom line, and this, sounds a bit flippant, it's not meant to be, it's bad luck. You get these things, it is just bad luck. There's nothing that you have done for yourself. I've got a patient who's a psychological mess. He's an American guy, not that that's an issue, and he was on the front page of Men's Health magazine about 10 years ago. He's an absolute specimen of a bloke. He's ripped. And he was a semi-professional American football player. He's lived on green tea. He's vegetarian. He's never smoked, never had a drink in his life, and he gets mantle cell lymphoma. And psychologically, that's destroyed him because his entire life was focused on being super healthy, so these things wouldn't happen to him. And can I persuade him to have a drink? No. So he's he's continuing with this lifestyle despite. I've treated him, and it's all gone away. But psychologically, that's really hard for this guy because his whole, being. He's very fit. And to go back to the point I said earlier, the fact that he's really fit means I can do anything I like. He's had a bone marrow transplant, but that's quite difficult, really, for him.
We do have another few questions around. You were talking about looking at predictors for the future. So the genetic testing. You were talking about a clinical trial that you've got. Because obviously there are, in other lymphomas, I suppose, there's ways we're looking into, can we predict how a lymphoma may act in the future, but also are there genetic testing in sort of follicular and mantle cell that we're sort of looking into, and that's the study you were saying?
Well, yes. As I was just presenting some of that stuff. Again, one of the principles of medicine, and this is for you patients to listen to, I guess, and agree or otherwise, is never do a test unless you're going to act on the results of it. So if you do a test and you find something, what are you going to do? And so we recognise some prognostic factors in certain lymphomas, but it makes no difference how I'm going to treat you. So actually, do you really want to know that your prognosis is worse than if you had this mutation or that mutation? Some people do, but it makes no difference what I'm going to do. And the other thing is statistics are meaningless to the individual. Okay, so if I said you've got a 1 in 100 chance of being cured with this disease, and you're that one person, great, but you've spent 5 years, worrying about it. So they're only useful, these tests, if I find you've got this, I'm going to do that. I'm going to do something different. So we've just recognised this year, in the context of mantle cell lymphoma, and this will not be you, I can promise you, there's a certain mutation that we recognise confers a really bad prognosis. So these patients, when we give them treatment, they'll progress early. You give them treatment, it's not going to work very well. Even the new drugs don't work very well. So we can see that now. It's a very small proportion of patients, but in those people, we need to do something different. And now we've got something different we can do. It's worth checking it. Because previously, what we do is we just treat people, and if they responded well, fine. If they didn't respond well, then we do something else. So you just kind of gave it and saw what happens. Now we can do something different, then we should do something different. But there aren't very many examples of where there's a test we're going to do that's going to actually inform how we manage people. For as long as I've been a consultant, and that's a long time, there's been this dream that you're going to do a gene expression profile on somebody. You'll take the tumour, you'll do a whole gene profile, it'll tell you the diagnosis, it'll tell you what treatment to give, and it'll tell you what side effects you're going to get from the treatment. Still not happening. It probably won't happen because actually we're very complicated humans. We're not tissue culture, and lots of things interact and affect how treatments go. So that might be the future. It might certainly be It might be more useful when it comes from a diagnostic point of view, because looking at genes is far more black and white than a pathologist looking at cells down the microscope. So it might be helpful in a diagnostic perspective, but right now it's not actually helping how we manage. But perhaps what I talked about today will be the first of, and there may be others. There may be others. The other thing is there are drugs that target specific mutations. We're starting to see that. And so there's starting to be a rationale for maybe if you find this mutation, use that drug. But there really aren't very many. And Btk inhibitors, which is the drug I've spent a lot of time developing or working with, targets something called BTK, Bruton's tyrosine kinase, which is completely normal in patients with lymphoma. It's normal, so it's not mutated, it's not abnormal in any way, so it's targeting a totally normal protein. So if you'd done a gene expression profile, you would never have found anything abnormal there. It's just a very sensitive pathway, which you only find out when you give the drug and see what happens. So maybe we'll see. I'm increasingly sceptical about some of these things. That's what happens when you get a bit older.
Definitely. And that leads into another question from one of our patients. So, like you said, Simon, you're not going to do a test, only doing a test if you're acting on it. So a lot of patients sent through questions, for example, with standard follow-ups at the moment. So you might have one patient's been told, you know, a CT PET scan for 6 months, every 6 months for 2 years, and then we don't scan. And obviously a lot of patients at that point are like, if you're not scanning and you can't tell in my blood tests whether I've got my follicular or mantle cell back, how, you know, it's not very reassuring, I suppose, for them. But like you said, if you're not going to act on that, if they haven't got symptoms.
Do you know, a lot of that is explained to the patient right at the beginning what you're going to do and why you're going to do it. So I'm going to treat you like this, and when that's finished, this is what's going to happen. So, for example, when I first moved to my hospital, we had hundreds of patients being followed up with aggressive lymphoma, most of whom were cured. And they were coming every 6 months or every year, and it was a very pleasant conversation because they think you're great and, you know, they're normal. But then none of them needed to be there. You know, they all shouldn't be there. They should be out. In fact, there was one guy who was really upset when I discharged him from the clinic because he'd wanted to emigrate to New Zealand, and because he was coming regularly to hospital, albeit every 6 months, he was not allowed to emigrate. So he was really quite angry with my predecessor. So now if you come to me with diffuse large B-cell, you're going to get this, and after 2 years, I'm going to discharge you. So everybody, when they get there, they know that's the situation, so they're not anxious. It's just in that the time when you're changing your kind of follow-up policy. And I think that's happening around the world because basically we're curing more people, so we've got more patients in our clinic. But one of the things you need to do is get people back to normality. And part of being normal is not coming to hospital, for whatever reason. So it takes you out of that mindset that I've got an illness because I'm being reminded every 6 months because I come to hospital to I'm fine, I don't need to come to hospital. And with the indolent diseases, doing scans in something that's completely normal, clinically normal, is of no value because I'm not going to treat somebody like that. You've got to be unwell before I'm going to treat you. So that's the point, I'm going to do the scan. So my practice is not to routinely do these things, but wait until the patient gives me a trigger to do it. That's not, you know, certainly North American practice isn't that, and I suspect some Australian practice won't be that, you know, regularly scanning people. But then patients start to expect a scan, and if you don't get a scan, you get anxious because you haven't had a scan. It's all what you're conditioned towards. But, you know, I just come back to what I said earlier. I'm not going to do a test unless I'm going to act on it. And the other thing that we're looking at, particularly follicular lymphoma, actually, because a lot of patients with follicular lymphoma are going to be fine for donkey's years, you know, decades. I'd rather you told me when you're not right and I'll see you then, rather than me seeing you when you're well. So having a kind of a slightly different follow-up approach, we put the onus on the patient. If you're not right, these are things I want you to worry about. And if you've got that, you come and see me. You're going to have the same things as everybody else, so I'm not your GP. Don't come and see me for everything, because I'll be rubbish at that. But these are the kind of things I want to know about. Or, alternatively, go and see your GP. If he's worried, he rings me, I'll see you straight away. So having a kind of, this is what we've got now, a kind of open access clinic, where the patient will actually ring my clinical nurse specialist, she usually advises him to see the GP if it's all a bit non-specific. And if there's an anxiety, then we'll see you straight away. And that's a much better use of resource than you coming every 6 months, because we know, certainly with most lymphomas, you're going to tell me when you relapse, I'm not going to tell you. And routine follow-up, and certainly routine scanning, almost always misses it. You know, so the scan will be normal. So nobody scans well, I've got to be careful what I say now. Aggressive lymphoma, you don't scan people. There's no point, because the trials have been done regularly scanning people rather than waiting for the patient to get symptoms. Because you do a scan today, it's normal. 6 weeks later, the disease can be back. It's a waste of time. And the other thing, again, coming back to what I said earlier, you don't get something for nothing. A CT scan's a lot of X-ray exposure. If you're going to live 20, 30 years with follicular lymphoma and you're having CT scans every 6 months, you're going to get acute leukemia from all the X-ray exposure. So you don't want to do that. So it's all balance. Have I scared people now? Oh. No. So for the indolent lymphomas, early treatment makes no difference. So if you're asymptomatic, I'm not going to treat you. You've got no symptoms at all, I'm not going to treat you. So I'm not going to treat you until you've got disease causing problems. And the other thing with follicular lymphoma, which is well described, which sounds a bit odd, is it can go away by itself. You can get spontaneous remissions with follicular lymphoma, unexplained. It's not due to any particular, living under a pyramid, having coffee enemas or anything, and it happens. So leaving people alone is often a very good thing to do. Yeah. Yes, sir.
I have non-Hodgkin's lymphoma. I've had it since 1983.
Wow.
They decided to leave it alone.
That was a smart move, isn't it?
Not tinker with it.
Yeah.
I think God's up there saying they don't want that mongrel up here yet. I tend to like having the scans. I
Yeah.
get CTs because I've had tumours in places that I didn't even know they were there. And they didn't show up unless I started to feel lethargic, which were the types of symptoms I was told in those days by Terry Frost. I just kept going.
Yeah.
Life was good and didn't have any problems. So Simon Durham, who looks after me,
I know him.
is he's just going to scan me in 6 months and see how I am. I just had a bit of muster. But it went well. It was fine. I've been on Mantle or rituximab. I sort of think that there are some things that scans can pick up that your normal physician can't.
Well, that's true, but it's the balance, and PET scans often cause more problems than they solve, because you see things and you don't know what the hell it is. But the trouble with regular scanning is the potential it can cause harm, if you like, not just the chronic exposure to radiation. You might actually pick up things that you end up having biopsy here, biopsy there, and it was nothing to worry about. It's a difficult balance, but and again, because of when you were diagnosed, your kind of expectations of how this is managed are completely different than if you were diagnosed today. So if you were diagnosed today and you saw me, you wouldn't be worried about scans because they wouldn't be part of the conversation. Whereas now it is. You've got that legacy of how you've been managed, so that's an expect. There's nothing wrong with that. I've got patients like yourself who find that reassurance, and I'll do it because one of the things that's important in some patients. This isn't you. Some people get really, really anxious, and they find the scan extremely reassuring, just as coming to clinic can be. So I said I discharged all these patients. Some patients I can't discharge because they find the reassurance of coming to clinic, even though it's just a process where you stick your hand on their tummy and say everything's fine. That for them is the reassurance that they need to get on with life, and I have no problem with that, because that psychological, help is of value for them. And what you're doing as a doctor is treating all of you, not just not the lumps. It's all of you.
I wouldn't say I'm blasé about it. But
No.
I have the understanding that you can't pop down the shelf and get a bottle of pills and get over it.
Yeah.
It's something that I'm certainly mindful of, but it doesn't take over my life.
No.
And I just follow the guidance of my physician.
Yeah.
If he's happy with the progress, I am too.
Yeah. I wouldn't argue with that.
Second question.
Oh, here we go. Yeah.
I noted recently there was a court case in America where it was found that glyphosate had caused the leukemia, or was it lymphoma?
Weed killer.
Lymphoma
Yeah.
of this groundsman,
Mm.
which, and I was watching Four Corners, who did this in more depth, and part of that show they said that 90% of American corn is sprayed with glyphosate, and it is grown with a genetically modified concerned me that somewhere along the food chain I could ingest corn that was sprayed with glyphosate. And
Yeah, I don't know. I mean, I think I don't think you can do anything about it, and you know how much that is actually linked to the generality of lymphoma. I think it's unlikely. I think if you're in that profession, you're exposed to a lot of these things, and I think maybe it's the actual amount of exposure is the issue rather than the agent itself. But you know, it's out of your control and my control. But we're not seeing an exponential rise in lymphoma as a consequence of people changing eating habits. You don't see any difference in vegetarians or non-vegetarians or certain diets. Even actually, I mean, you do get some racial variance. So if you look at the incidence of lymphomas across the world, certain lymphomas are more common, for example, in Southeast Asia than they are in the Western world. So mantle cell, I've been to China 4 times now. When I first went there, mantle cell lymphoma didn't exist. Never saw it. You go there now, there's loads of it. It's not that the disease wasn't there, it's just they're diagnosing it now. So, as medicine gets better, you start seeing these things. But it's very difficult. And one of the things that, again, that I see regularly is, you are suddenly diagnosed with lymphoma. Why did this happen to me? That's your first question. So you're going to think, well, I had a car crash 2 years ago, I got divorced a year ago, my mum died. There's something in your life that's stressful that you want to blame on why this has happened. Because that's happened to everybody. Everybody's had that stressful event. So you're looking for something that might have caused it. It's human nature, Why would this happen to me? And I guess diet's another component to that. As I said before, it's bad luck for just about everybody. But, it is human nature to try and find a cause. But I don't know the whole story behind that. And inducing cancers in a test tube is very easy with lots of things. It's slightly different in a two-legged model, slightly different.
There are also a couple of farmers who got lymphoma.
Yeah.
And when they went to their doctor, they said, "Oh, you've got the farmer's disease." And the implication was that it was associated with glyphosate.
So I've got so I work in Plymouth, which is a big rural part of the world, so Devon and Cornwall, and we don't see more lymphoma in farmers than non-farmers. If it was truly an occupational thing, you'd see it, and we don't see it. So, and again, it's what I said earlier. It's one thing being exposed to something like that. There's something that exposure, something about you that having been exposed, it triggers an event. So, it's never quite as simple as it might be made out to be. So you take smoking, for example. This is terrible. 50% of smokers live a completely normal life. 50%. 50% don't. So, you take the most carcinogenic thing there is, cancer-inducing thing there is, and only half of people get cancer or problems, but half do. So if you want to, it's not a lottery ticket you want to buy that, is it?
I was just wondering about your opinion on stem cell retrieval as an insurance policy for recurrence.
Yeah, don't.
Sorry?
Don't do it.
Don't do it.
Is that the answer? Why? Well, why would you? You mean collect your stem cells?
Yeah.
Yeah, because...
Autologous.
No, because if you're going to do it, you take the stem cells at the time you're going to be doing it. You don't need to be storing them down. It's of no benefit to you. Wouldn't do it. But they used to do what was called rainy day harvests. We used to do a transplant and store it. We never used them. We're there for years and years and years and years. And actually, if I've got some stem cells stored for 10 years. And I've got you, I'll actually take your stem cells right now, thanks, rather than ones that have been stuck in the freezer for 10 years. Because when I thaw them out, half of them will die. So, you want them in you. Now, you might say, well, there might be some tumour in there, but there might have been back there as well. So, no, you want the stem cells around the time that you're going to do it. Now, you might say, I might be too old for that. Well, if you're too old for it, it's the chemotherapy that is the thing that precludes you from having a stem cell transplant, not having the stem cells. So to have a stem cell transplant, you have to have high-dose chemotherapy. So if you're, old, but you've got stored stem cells, I'm not going to do it because it's the chemotherapy that's going to knock you off. So I would not do it if I was you.
I thought the idea was so that because follicular gets harder to treat each time it recurs, so they give you more heavy-duty chemotherapy, and then if you've got the stem cells sitting there, they can wipe out your bone marrow with the strong chemo and then give you the stem cells back.
No, you do that type of treatment very rarely in follicular lymphoma. And you'll only tend to do that in a young person whose disease is behaving in a very aggressive way. So if you give standard chemotherapy, whatever it is, and the disease is back within a year, say, then you're going to dial it up a little bit, because you know in that situation being more intensive is going to buy you, it's going to be more better for you. Things are evolving with follicular lymphoma. I mean, the average survival of follicular lymphoma now is 20 years, you know, and the frontline treatment's going to buy remissions of 7-8 years these days, and that's 20 years based on treatment 20 years ago. So the drugs I'm playing with in clinic are the things that might be available in 10 years from now. So there's a whole evolving field, and stem cell transplant is a pretty crude thing to do. It's just basically high-dose chemotherapy. That's all it is. It's high-dose chemotherapy, which would ordinarily kill you because it wipe out your bone marrow. So you take your stem cells out, so you can dose up the chemotherapy, and then the stem cells go back to rescue you. That's all it is. It's nothing clever. It's just a trick to give you high-dose chemotherapy. But you only do that in a young person whose disease is behaving in a very aggressive way, more like an aggressive lymphoma. And I'll have your stem cells right now, thank you, rather than stuff that was stored 10 years ago. If you had cells 10 years ago, you haven't got disease that's behaving like that anyway. So I wouldn't. Yeah.
No.
Well, don't be. Just listen to what I said.
Yeah, I've just got a few questions there's a lot of follicular patients online as well.
Yeah.
Then would you now see the follicular patient, if you're not using stem cell transplants, we've now got enough of new treatments, so it's just a pathway of new treatments rather than the harsher stem cell?
I think so. I mean, one of the challenges with follicular lymphoma is how you sequence your therapies, because what you want to do is keep patients alive as long as possible with as good a quality of life as possible. So part of that is not over-treating people. Part of that is leaving people alone. Part of that is waiting until they've got disease that actually requires some kind of treatment. There are a range of chemotherapies that work. You know, you can choose one or the other depending on how the disease is behaving, how old the patient is, what kind of other problems they've got. And, you know, some of the gentler forms of treatment you can use again. So you can give, say, CVP. It's a very British thing to do. But if you give that to somebody and the patient relapses 7 years' time, you can do it again. So, it's how you sequence these things. The new drugs in follicular lymphoma, things called PI3 kinase inhibitors, have all been dogged with side effects. They're active, but they're called side effects. There are new ones coming. They've got fewer side effects. These are tablets. They look active. We don't yet know how best to use them. I mean, I'm doing trials with these drugs right now. So there's lots of these things coming. Follicular lymphoma, because it tends to come back and back, there's a big industry out there trying to create new drugs.
A common question for us too is frontline treatment. What is the best treatment? Bearing in mind Australia is probably ahead of the UK, you know, with what we
You can't
have.
give maintenance though, can you?
I don't think we are, but anyway. So I think, the patients are often given options themselves, and it's obviously very difficult for a patient to make that option. So what would you use in the UK frontline?
We've got the same drugs that you have, by the way, frontline.
Yeah,
Yeah, we have.
Well, we just got more listed. But what is your say preferred option frontline and then at relapse?
So it's what I said before. It depends on the patient, their age, their fitness, how the disease is behaving, how it presents. So in a young patient with disease that's moving pretty quickly, patients say, well, I'll use CHOP, and because I think that gives you. You know what you're going to get with CHOP. It works very well. It's the treatment you use for aggressive lymphoma. So if there's any suggestion that disease has progressed in any way, you've got a transformation, then that's the right thing to do. Bendamustine may be as good as CHOP. It's got a slightly better side effect profile, but it does have late effects that CHOP doesn't have. So infections can be an issue with bendamustine, and there can be some deaths from bendamustine late. So it's a balance. And the reality is you're probably going to use both of those agents at some point. So it's how you sequence them. So again, it depends on the individual patient in front of you. So there's no right answer. There's no you must use this treatment for everybody with follicular lymphoma. You've got a range of 3 or 4 things that you could use, including rituximab by itself. So just single agent rituximab in some patients with low volume disease or elderly patients, or a little bit of radiotherapy. There are things that you can use that will work, and you're more inclined to use that in an older, frailer patient than, say, a young, fit patient where you might want to be a little bit more aggressive because you're going to buy more time then. And it's about what you're trying to achieve with your therapy. because we're not curing people with follicular lymphoma, but you're in it for the long haul. So in a young patient, you want that remission to be as long as possible, so you'll be inclined to be a bit more aggressive. But in an older patient, you don't want to cause problems with your treatment.
I think that's really reassuring for patients to hear that, because we can be sitting in a room with 10 patients
And they've all been treated differently.
Treatment,
Yeah,
and then
yeah.
you're worrying about that. So I guess the message is that, yeah, it sounds like you can actually be treated based on you, the individual, and getting back to your previous comment, have a second opinion if you
Yeah.
just want to be reassured
Yeah.
that you are heading in the right direction.
So I could see 5 new follicular lymphoma patients in a row and treat them all differently. And one, excluding watching, which you're going to do if patients don't have any problems. You like to be more aggressive in a young patient who's got nasty disease causing problems, and an older patient you want to be quite gentle. So it's very individual. So there's no right answer. It's not like diffuse large B-cell where there's one treatment. It's R-CHOP, and if you can't tolerate that, then you're going to use modified R-CHOP or something. But that's wherever you're in the world, that's the treatment. But that's a very unusual scenario. Most lymphomas aren't like that. You're going to base it around the patient sitting in front of you.
Would you do the same then with mantle cell? Would that be the same advice, or would stem cell transplant then
Yeah, I think I think mantle cell's broadly similar. Actually, mantle cell falls into two. At the point you need to treat somebody, so forget the watching. At the point you need to treat somebody, in a young patient, you're going to be aggressive. You're going to give them a high-dose chemotherapy approach with a transplant and rituximab maintenance, which you can't get over here, but we can.
Working on it.
Yeah, it makes you live longer. Yeah, and that's pretty much standard of care across the world. The chemotherapy bit can vary. There are 3 or 4 different varieties of chemotherapy. It's all wrapped around the same drug that's the key drug, cytarabine. So it probably doesn't matter which of those you use, but that's the treatment choice for an older patient population. Then it's either CHOP-based or bendamustine-based treatment, and they're broadly equivalent. But again, you're going to use these drugs. You can use both of those drugs probably in the lifetime of the patient. It's how you sequence them.
And because you're an expert in the mantle cell, I guess, is a message to Australia that we're actually disadvantaged because of that rituximab maintenance that we currently don't have.
There's no question. There's no question. There are very, very few drugs that have proven a survival benefit in mantle cell lymphoma. But rituximab maintenance is one of them after transplant. And in fact, there's a big series just published from the Czech group looking at survival across the board in mantle cell lymphoma, maintenance versus no maintenance, and there's a huge difference in outcome.
Yeah, I think I've seen that.
Huge difference.
Yeah, okay, that's something that we really need to address.
Yeah,
here.
definitely.
Yeah. Any more questions? Because I've taken over the microphone.
No one address it for me. No, I don't have another question. I've used up mine.
Sorry, I'm from Roche. It's just with bendamustine, it's not reimbursed, theory maintenance.
Yeah, well, actually,
with CHOP it is.
Is it? But it's not post-transplant. It's not.
Okay. Is that
Because that's where the survival benefit is. Yeah, yeah.
Okay.
Post bendamustine, there's no benefit, so there is no point. Post CHOP, there is. In fact, I use CHOP followed by maintenance rather than bendamustine frontline in mantle cell, because I think you get much more for your treatment than if you give benda. I use bendamustine later. It works very well. So again, it's about how you sequence things. But post bendamustine, there's no evidence that rituximab adds anything in any setting. So there's no reason to fund it. So you might disagree.
Yeah, look, I'll just jump in there and just provide the Australian sort of landscape. So in fact, under our arrangements for reimbursement for rituximab, the PBS makes a distinction between induction chemotherapy with rituximab included as part of that, and then giving rituximab by itself as maintenance treatment. So at the moment, for any B-cell lymphoma, doesn't matter what subtype it is, as long as it's got the protein that rituximab binds to, which is CD20, then you can use rituximab in combination with chemotherapy. And now with follicular lymphoma, we can use Gazyva as well as an alternate, and that's in that situation. For maintenance therapy, we can only do it for follicular lymphoma specifically. It doesn't allow us to do it for mantle cell lymphoma or diffuse large cell lymphoma. So within the lymphoma space, maintenance treatment with rituximab is only available in follicular lymphoma. And that's the way it is. So, I mean, obviously that's where groups like Lymphoma Australia are very important, because they can continue to provide advocacy and sort of lobby the companies and the PBAC to ultimately get these things over the line, particularly in a circumstance like this where there is clear evidence of benefit. So it's a big hole in our current therapeutic strategies.
I'd also say patient groups are listened to far more than we are. Okay, so I can go and shout, say, you know, I demand this, but they assume I'm being funded by Roche or whoever to say that. Of course, you're not, but you have your vested interests are slightly different. So don't underestimate how powerful your voice is. Is there any surprise every breast cancer drug gets funded? You know, because they make a lot of noise. That's why. It's the power of the lobby. There's no two ways. It's the same where I am. The power of the lobby. So it's in your hands to a degree.
Any more questions from?
I think they're all a bit worn out, aren't they?
Yeah, well, you've done. Any more from Shana with any on there? Yeah, all right. Okay, and I guess just leading from that, in Australia, we do have a regulatory system where our government does value the patient voice, and I think that's where we've been able to have some of our drugs be approved more recently. So it's great to have people like yourselves here and everyone online as well, because the next time a submission or new medicines are put out, we ask our patients, please go on to the government website, fill in the form and tell them about what your lymphoma is and how these medicines are helping you at the moment or how they could benefit you. So if you have mantle cell lymphoma and the submissions come up for maintenance MAB-Thera or rituximab, we need to hear about it from you. That's how we've been able to get more drugs approved for even the follicular lymphoma. That's been an amazing space. A decade ago, what did we have? R-CHOP. Oh, actually in Australia, we only had CHOP. And then we moved on to R-CHOP. Now we have patients saying, which one do I have? So we can eliminate some of those harsher therapies and just go on to the chemotherapies. So, but I guess I can, if no more questions here, on behalf of Lymphoma Australia, I would like to thank all of you for coming today. This is what we are here for. Everyone online, we have people from across Australia listening in. We hope to do these more often, and particularly so that we're looking at specific subtypes, and that will help each of you with your type of lymphoma. Without the wonderful expert advice from Doctors Professor Rule and Dr. Jason Butler, we wouldn't be able to bring this to you, but we really appreciate the time and the effort that you actually share all your knowledge with us. So thank you so much.
Absolute pleasure.
And we have alcohol. Where is our alcohol? So,
Thank you for organising.
Yeah,
no,
absolutely.
thank you. This is what we do. This is what we want to do. We want to be able to get more medicines to Australians, clinical trials. The other thing is learn about clinical trials. They're the way to the future. In Australia, we are not as good as the UK.
So let me just tell you, we're about to publish in the British Journal of Haematology, I'm going to blow my own trumpet now. If you were diagnosed with mantle cell lymphoma in my hospital, you live twice as long as if you're diagnosed in the Yorkshire region of the country, where there's other comprehensive database. And do you know why? It's because 60% of my patients go into clinical trials. 60% go into clinical trials. So ask about a trial.
Yeah, definitely. If you have to travel for a trial, even consider the trial.
And patients will travel.
Yeah.
Doctors are reluctant to offer them to patients. I'll tell you an anecdote which is very instructive to me. I saw a guy with mantle cell lymphoma. He'd failed 3 lines of treatment. He drove to see me from Manchester. Now that to Plymouth, that's, if you don't know, that's a long way, right? So he's 5.5, 6 hours in the car. Very ordinary bloke, wasn't wealthy or anything. He turned up and I said to him, look, it's very difficult. I've got a trial of a drug, but, you know, you'd have to come once a week and that's a lot. And he looked at me and he said, that's for me to decide, not you, isn't it? So, and he came every week and he lived 5 years, that guy. He went on a lenalidomide, then he got on ibrutinib. So, you know, you offer it to the patient. They decide whether they're going to invest in that or not. And that was a big lesson to me, because I think most doctors take the view that it's too much for the patient. Well, ask the patient and they'll tell you. And that's what we should do.
So how do we know where trials are being conducted? Because it was not...
It's a good question.
Maybe 12 months ago, in this building, there was a panel, it was organised by Berghofer. And there was a panel, there was people from all around the world,
Yeah.
doctors, professors, and I asked the question, and they said, look, mantle cell, it's not on the radar, there's not much money being spent, there's not many trials happening.
simply untrue.
That was not 12 months ago.
Yeah.
So
It's difficult. So in the UK, so the Lymphoma Association in the UK is a central place where people could ring and they'll tell you. They'll tell you. So they've organised that now. So you've got mantle cell lymphoma, you live there, the trials are here.
Yeah.
And these are the trials.
In Australia, I think for lymphoma now at the moment, we have a couple of good ways. We have what's called ClinRefer app. You can actually download an app and it will actually, you punch in mantle cell locations and up will come the different trials. What happens though, sometimes from a patient perspective, is you look at it and you go, oh my gosh, what does that mean to me? The next point of call can be ring us. We now have lymphoma nurses on a hotline and they can actually help direct you to what is it, the trial that might be suitable for you, and then you can actually go and ask your doctor. But also remember, one thing is, when you're sitting with your doctor, say, what clinical trials are available for me? If you don't ask, but at least if you're asking, and if you go away and find one, come back and ask about that one as well. We've now got 500 nurses that have registered up to Lymphoma Australia across Australia, and one of the big things that we want to do is educate them about clinical trials so they can tell their patients about them as well. But we're getting there, but I think UK is probably further.
It's very centralised and organised, yeah.
But again, thank you so much.
No, it's a pleasure.
Yeah, so this is your wine.
Oh, thank you very much. Oh, nice. Very good, I'll take that.
So now he's labelled Lymphoma Australia. So
I'll show that to the Lymphoma Association back home.
Yeah,
so,
well,
they haven't got any bags.
We do a lot of work with them as well. So we're all part of the Lymphoma Coalition. So but thank you so much.
Well done for the work you do. It's very, very good.
Thank you,
Thank you.
Dr. Butler.